say something I can't reach, or something that cannot exist. I feel like I became a zombie. Not alive, but I'm still walking.
Pick up a lab coat from the rack. Well done. Now find a glove box and click on it. I see you are now all equipped for lab work. Since drug X has diuretic properties, it is highly likely that it acts on the kidney. So, move to the hollow table to check out the hollow kidney. Not so long ago, I 3D scanned a mammalian kidney. Check out the different kidney structures on the hollow table and raise your lab pad when you are done. Click on the lab pad for more information. Are you done studying the kidney structure? Great. Let's see how familiar you are with kidney tissues and their functions then. Find the renal artery and click on it. Nice. Let's keep going. Where are nephrons located? Don't forget you can always check for the answer on the hollow. Absolutely. Nephrons extend from the cortex to the medulla, although different structures are present in each tissue. Find the descending limb part of the loop of Henle. Which structure reabsorbs glucose and amino acids, and secretes creatine? That's right. You rock at this. Finally, what are the known functions of the distal convoluted tubule? Awesome. You seem to know your kidney structures very well. That concludes our little crash course, and we can get to work with drug X now. Know that you can always come back to this hollow table at any point during this simulation if you want to refresh your memory. Alright, let's check out a first possible mechanism for how drug X can affect urinary output. At the glomerulus, blood is filtered into the proximal tubule. If the rate at which blood is filtered increases, this could increase urine production, and therefore is a possible mechanism of action for drug X. Look up the glomerulus on the hollow table. A standard way to estimate glomerular filtration rate is to measure the loss of creatinine through urine. Creatinine is a product of skeletal muscle metabolism. Most of it is passively filtered at the glomerulus and is not reabsorbed in the bloodstream, though a small amount is also actively excreted in the proximal tubule. We can calculate the glomerular filtration rate by measuring urinary output as well as the concentration of creatinine in the bloodstream and the urine. However, we will also have to assume that all the creatinine entering the kidney is filtered into the urine in the glomerulus. Let's see if you can do it. Move to the analytical workbench by clicking on it. Turn to the left of the workbench. You can see the table of data on the computer screen, and the equations on the wall. The data comes from the preliminary tests of drug X as a diuretic from hospital patients, and will help us calculate the glomerular filtration rate in the presence and absence of drug X. If drug X is a diuretic that impacts the glomerular filtration rate, what would you expect? That makes sense. An increased glomerular filtration rate would lead to a higher volume of fluid entering the tubule, and ultimately to the secretion of a larger amount of urine, thus a diuretic effect. Let's see if that's what we observe in the data from a hospital patient. With the data and the equations available to you, calculate the glomerular filtration rate before taking drug X. You can use the calculator in the top right corner of the lab pad, next to the sound settings. Nice one. Now let's do it again for the other set of data, after taking drug X. Now calculate the same glomerular filtration rate, but under the effect of taking drug X. Correct once again. I will update the table accordingly, and you can see the complete table on the computer screen. Comparing your results between the two experiments, does drug X affect the glomerular filtration rate? Do not forget you can slide down your lab pad to see the table on the screen. Indeed, so it seems drug X does not affect the glomerular filtration rate, so that is one possibility we can eliminate for the mode of action. A second hypothesis is that drug X could also be interfering with the secretion of antidiuretic hormone or the aldosterone hormone, or their respective signaling pathways. Those hormones both act in the kidney, although in different fashions, by promoting higher reabsorption of water and thus a reduced urinary volume, hence the antidiuretic effect. Knowing that ADH and aldosterone are both antidiuretic hormones, which clinical results would be consistent with the hypothesis that drug X acts to increase urinary output by affecting ADH or aldosterone signaling? No, this is incorrect. No, this is incorrect. Good thinking. Downregulating one or both of the antidiuretic hormones should decrease their effect and thus, increase the urinary output. Unfortunately, results from a recent clinical study suggest that patients receiving drug X have normal ADH and aldosterone levels, and have normal responses to injection of ADH or aldosterone. Therefore, there is no evidence that drug X acts by inhibiting either of those two hormones, and we can safely discard this hypothesis from our study. We have now excluded two hypotheses so far. 1. That drug X affects glomerular filtration. 2. That drug X affects antidiuretic hormones. I have another suggestion for us to test. Taking a different approach, many diuretics act by affecting the reabsorption of salts in the renal nephron. Testing humans is complicated, but we can do this with a rat right here in the lab using a perfused tubule preparation. We have all the necessary material here, so I suggest we try this out next. Move to the dissection workbench by clicking on it. I have a rat here that was humanely euthanized, so you do not need to worry about this part. I will guide you step by step through the dissection of the relevant structure from the nephron and setting up the reabsorption experiment. We first need to dissect the rat and find the kidneys in the abdomen. Pick up the scalpel on the workbench. Dissect the rat. After putting down the scalpel, cannulate the kidney inside the rat. Good. Using this cannula I perfused the kidney with a saline solution containing collagenase, which disrupts the extracellular walls and will allow us to extract the nephron from the rest of the kidney. Next we are going to perform a coronal section of the kidney to get access to the nephrons. Perform a coronal section using a scalpel, and watch the outcome on the screen. Now we need to dip this coronal section into cold collagenase containing dissection saline. Once again, the collagenase will help break down the tissues by disrupting the extracellular matrix so we can isolate a nephron from the medulla and the cortex. The buffer composition will also help stabilize the cells to keep them intact as much as possible. Using the scalpel, transfer your coronal section to the saline bath in the petri dish. You can see a microscope image of the coronal section on the computer screen. For the next steps, we will need to use micromanipulators under the microscope as the operation is quite delicate. You can see the manipulators and the pipettes above the microscope plate, below the objectives. Place the petri dish with the coronal section under the microscope. Watch the 2D section with the nephron on the screen in the center of the workbench. Many diuretics target the reabsorption of sodium in the body, as reduced sodium retention would mean lower water retention, thus increasing urinary output. Sodium reabsorption occurs in different sections of the nephron, including the thick ascending limb we are now going to dissect.